live stream and ask her to confirm when that's gone live.
Thank you very much. Well, good evening, everybody, or I suppose I should much rather say good afternoon and still pretend we're in the throes of summer as it's sunny outside. Can I welcome staff, guests, friends and my fellow board members along to our annual general meeting of Herefordshire and Worcestershire Health and Care NHS Trust this evening. For those that I've not met and don't know me, I'm Mark. I chair the board of the Trust and will hopefully try and keep some sort of order this evening. If we could bring up the agenda, please. And you'll see from the agenda there, I remind everybody down at the bottom there that this meeting is being recorded and will be placed upon our website early next week, as you can see. I would also ask everybody that's attending on the Teams link to keep yourselves on mute so that we can keep the smooth running of the meeting, please. As you can see from the agenda there, I'll give a quick introduction and changes to the board that have happened since the last AGM. We'll then move on to Robert, our Chief Executive, who will give a quick summary of some of the key moments of the year 23-24, because that is what this meeting is about, that financial year that ended last March. We'll then move on to our Director of Nursing and Quality, Natalie, who will give us an overview of some of the priorities and how we did against our set priorities. She will also then say a little bit about the priorities we've set for the current year we're sitting at this moment in time. We'll then move to Denise, our Director of Finance, who will cover our financial performance in that year. Before then we move to perhaps what is the highlight of our meeting this evening, which is a presentation regarding our neighbourhood mental health teams and how the transformation within those teams has gone over what will now be probably the best part of 4 years and what it looks like into the future. There'll also be then a segment at the end of the meeting for any questions that may arise through what has been said. So with that as the agenda, if we could move on to the next slide, please. Although, as I've stated, this meeting is about the financial year 23-24, what I wanted to do was just set out very quickly the changes in our board since the last AGM. So some of these changes have actually taken place this year. And perhaps one of the main changes are our long-standing Chief Executive, Sarah Dugan, has retired to be replaced on an interim basis at this moment by Robert Mackey, that you'll see top and centre. And that has also meant that Robert's substantive position is filled by Denise Lewis, who is our interim Director of Finance. But there have also been some other changes with Tessa Norris and Jamie Morris both stepping off as non-executive directors. They finished their term and retired. We've also got two new people that have come on the board just very recently, actually. Scott Parker, who you'll see bottom right, is our newly appointed Director of Improvement. And on the far left, on the bottom row, is Colin Horwath, who is a newly appointed Associate Non-Executive Director. All the others you see on the screen there have been in place since the last AGM, and collectively we are the board and we are responsible for the oversight and running of the organisation, and responsible to NHS England and the Secretary of State for doing all we can to provide that excellent patient care that we strive to give. So with those changes now outlined, and no further ado, because we're pushed on time this evening, if I could hand over to Robert Mackey, the Chief Executive, to give us a summary of the year 23-24. Robert.
Thanks, Mark, and good afternoon, everyone. It's a true privilege to be able to present our highlights from last year at the AGM this year. I've got a few slides which I'm just going to run through just around context, just to remind everyone where we are, what we do, and who we serve, and then we'll move on to a little bit about kind of those highlights, just to draw out those key moments for last year. So just in terms of our communities, our patients, our staff, got a few facts and figures on the slide for you here. We do provide services across both Herefordshire and Worcestershire, so we're serving a population of 800,000. We've got a note there on the right that demographically we're over 80% of the population identify as white British, although clearly it's really important that we tailor our services to be inclusive to all those other races, ethnicities and citizens that we serve out there. We've got some 4,500 plus staff that work for us, and we've got an ageing population, which I think is well understood across the nation, but it's something that's going to really drive the needs of healthcare and the services we provide over the coming years and into the future. So that's something that we are thinking a lot about. We are a provider of predominantly community-based services. Obviously, we've got inpatient services, some out of fixed sites as well, but we operate from a lot of sites across the geography. So we've got over 100 main sites. We clearly operate out of patients' own homes. So if you were to multiply that up for those, it's a lot more. But we've got a very mobile workforce, and we do deliver across 2 of the larger rural counties within the country, and that brings its own challenges in terms of how we keep connected, how we provide good services, how we're able to stay able to be focused and mobile to support our patients. Have the next slide, please. So just in terms of translating some of that into a few facts and figures, I know some people love a few facts and figures. I quite like them themselves, but if you look at overall contacts, we're just shy of 1 million contacts across the year. That's a huge amount of activity and testament to the great work all our staff do, and I'd like to take the opportunity to thank them for that here and now. We've split that up a little bit more for you on this slide, so you can just see some of those high numbers where they do come from. So lots of mental health contacts across communities, adults, older adult services. We've got the crisis line that was a fairly new innovation coming out of COVID, where we've got nearly 30,000 contacts. And then, as you can see, lots of contacts across our nursing and therapies and other services, whether that's for children, young people, or adults. We do operate some other specialist services, which I'll just touch on the next slide, but predominantly community and inpatient-based services. Could I have the next slide, please? Thanks. And then just to round this part up, this is actually how we organise ourselves. So we operate out of what we call 5 service delivery units covering that range of services. So we have a team that deliver our children's, young people and family services and some special primary care, so things like special dentistry, sexual health and so forth. And then we have county-wide community services and primary care integrated community services, which cover our physical health care across Worcestershire, both in the community and both across some of those community hospital sites we have and clinics, out to GP surgeries and other partners. And then we've got our 2 SDUs, which pick up our full range of mental health services, whether that's CAMS right through to older adults and those more specialist services that we provide across Herefordshire and Worcestershire. And a number of those services are on an integrated basis, although with a locality focus. Then, of course, to support all that great work that our teams do, we have a number of corporate services, which we've got represented here, which we split up across a number of different areas, but that covers the full suite of support services you would expect to see. I think the one I'd particularly draw out that's not overly visible here, but there's a lot of folk in there. They do some great work, particularly our estates and facilities team that support and are integrated with a lot of our frontline service delivery, as well as helping us maintain the estate and environment we work out of. So hopefully that just gives you a flavour and a reminder of who we are, who we serve, and how we go about doing that. What I'd like to do now is just move on to the next slide and really just talk about some of those key points from last year. And I suppose the first one, the key points, I've not said a highlight here. The first key point was really around, we had CQC inspections that took place across a few core services, and then a well-led inspection that happened last year. So that was February to June time. And we had a report published eventually in January. Now, I think it's well known that we had a very disappointing inspection, which revealed some difficult issues for us as an organisation to address, some things we need to face up to and some things that we are actively trying to improve. The that report, though, that process was really important for us as an organisation, and it has kick-started a significant programme of work that we've embarked on. What we've got on this slide is just trying to draw out some of those key points. So in terms of the report, and we started working on, if I can call it, the hot debrief that we got, so immediate feedback after the inspections that we were working on, which was well ahead of the final report that was published in January. But generally, some of those key themes that were coming out were the organisation was not as inclusive and welcoming as we would want to be. We didn't treat our staff and in some cases our patients, carers, with the sort of level of respect and civility that we would like. And there were issues around our governance and our risk processes and how we went about making decisions. Some of that, as I've said, was actually quite hard for us to hear, but we've risen to the challenge. We then went out in the summer and the autumn and talked to our staff. We had a big listening exercise that engaged over 700 staff to help us shape the programme of work that we needed to put in place to get better. We've also made big strides in terms of engaging with our partners, our communities, and our patients and carers. And through all of that, we've drawn together the improvement plan. Now, just before we move on to the next slide, I would want to emphasise there was actually a lot of good in that report as well. So there's a lot of things that our staff, our teams do really well, and it's easy for that to get drowned out by the things that we're not doing well on, but it is important to recognise that. So some of the work we did in community and acute mental health settings have improved and got better. There was an overall rating of good for how we treat our patients with kindness and care and compassion, and some of the safeguarding risks were managed well. But overall, that CQC rating was downgraded to a quiet improvement. So the next slide, if I can please, just picks up what we were doing about that. And of course, this does feed through into what we've been doing this year and some of the things that we'll be picking up and doing for the following year as well. I'm only really going to focus here on last year, although lots of this work has been moving at pace through this year from Easter onwards. So just to touch on this, we had some immediate actions that we must do from the CQC, 35 of those, and we've made some really good progress on that. Some of those were trust-wide, some of those were specific. On the call, and you'll hear from Natalie a little bit later, those specific areas we've picked up through our Quality and Safety Committee, and that feeds up to Trust Board via that route. But Natalie has taken executive lead on some of those, obviously with others such as Matthew and John keenly involved in that. But if I go back to the engagement, we engaged with staff to really find out what they thought. It was interesting. It was eye-opening, I suppose, at times, but the themes that were coming through very much chimed with what we were hearing from the CQC. Probably different emphases in different places, but that helped us to start to draw together a plan. What you'll see on the slide is we ended up with, alongside the CQC must-do actions, 6 key work streams that we've been working on around culture and diversity, systems, processes, some regulatory standards, risk management, communications, and working with our corporate and administrative services. And we made some really good progress last year, actually. We ended up with some commission work with a partner to help us with compassionate, inclusive leadership, and we just started those workshops, which continue this year. That's with A Kind Life. We approved at the board level our EDIE strategy, and we've got a whole load of actions that we're setting out to deliver on this year. And we've been doing work about reviewing and strengthening our governance, working with Good Governance Institute and so forth. We've also done an awful lot working with our staff, and you'll see on here it talks about Pulse Dashboard. We've really tried to major on getting feedback from staff as much as we can to help shape what we do, and that continues through this year. Other things that we did last year to tee us up in a good place for this year were working through how we get better patient carer voice and feedback. both working with partners, so talking to some of our partners and resetting relationships there, but also how we use some technology and some organisations to help us. So you've probably heard that we've worked quite heavily this year with Care Opinion, as well as on-site advocacy and existing friends and family tests and other things. So I think the reason I've spent on that is that probably is the biggest, most important thing that has framed what we've done. And it's clearly a key part for framing what we intend to do for the remainder of this year and into the year after. Lots of good work. Clearly, we're drawing that through what we do, and clearly more than happy to pick up with folk and talk through progress we're making on that. If I can move to the next slide, though, I just want to turn to the other area that we have, which is really how do we do against those strategic objectives that we set out as an organisation to achieve. One of the things we are doing this year, though, is we are reviewing our strategy. The strategy is coming to the end of its natural life at the end of this year. Sue is leading a process to engage with staff, our citizens, our partners to draw that together. And we're quite excited about how that's coming together. That will come together as a new strategy for our trust, which will come through Trust Board in January, actually, but lots of work around that. That feels like a really important way of encapsulating what we've been trying to do. However, I just wrote back from that. We do have existing strategic priorities, and I think at the AGM it's right and proper that I just run through how we progressed against those. So the first one of those is to improve the outcomes and reduce health inequalities, and clearly that's something that we're all trying to do across the integrated care system. I've already touched on a few of these. We've got things that we're quite proud about. So we have achieved the Silver Award for the Armed Forces Covenant. We're working actively to get to gold. Congratulations to our partners, Worcester Acute, for achieving that recently. We're aiming to get there shortly as well. I talked about the work we're doing around inclusion, some really important things that the board have done there, and setting out strategy and policy and actions that we're trying to take. And we've got some pockets within services where we are making some good progress on identifying those health inequalities and tackling those. That's definitely an area that we need to do more as we go into the future, but it's certainly an area we're trying to make some strides on, and the slide draws out some of the things that we managed to do last year. If I could move to next slide. Thank you. So the second strategic objective we had was around being ambitious and constantly innovate. Again, some great things that we've done, and plaudits to staff that have managed to do some wonderful things for us. John's on the line here, our medical director. We've been working hard to roll out our clinical strategy and use that to drive improvement across the organisation using, quality improvement techniques. Again, some really good progress on that, and it's something that's continuing to this year. I'll just do a quick shout out, if I can, for the work that's been done this year to lead up to our improvement conference that we've got in the autumn, where we're hoping to draw together some of that real positive work we've done and showcase it and inspire everyone else to drive forward in their areas. Some really good work across the system on frailty virtual wards, and we are able to show that we've had some great work piloting some of that and rolling it out. At the moment, we're working very closely with colleagues in Worcester Acute and Primary Care to work out how we can make that a sustainable model that we can roll out across the county of Worcestershire. I think most people are aware we've been doing a very large capital programme around improving our environment, and one of those high points has been the dormitories work. Last year, I'm really pleased to say we've completed the work at Elgar, and we're on track to complete that at Stonebow very soon. So that will be a massive upgrade in terms of the quality of the estate and accommodation and facilities and care environment that our patients are receiving. And just to reflect that there's things that we can do on a much smaller scale that have a really big impact. We have had a lot of work through charitable funds, through trust capital, through trust staff engagement and just downright enthusiasm, we've managed to deliver what's a fantastic bespoke therapy garden in Meadow Ward in Bromsgrove. It's attracted quite a lot of attention in terms of how innovative it is, and again, just thanks out to staff for all the work around that one. If I can move next one. So be efficient and effective, clearly a massive challenge, a massive priority for the NHS as a whole, and something that we've got quite a good track record of delivering across the whole breadth of that, if I can take it that. So clearly there's things around managing the money, and Denise will talk about that a bit later. But again, none of this is easy. It's down to lots of hard work from staff to do that, frontline support teams, to make sure that we make the money go as far as we can. And we've got a really good record around that, which we're pleased and proud of. Denise will cover some of that in more detail. But more broadly than that, we're doing some really good things in terms of digital. So the rollout of the EPMA, the approval, the contracting and letting of a contract for a new electronic patient record, which we're rolling out this year. Things that we're doing in terms of more fundamentally looking at pathways, completing changes in terms of talking therapies, the work we've done multi-agency around eliminating out-of-area placements. And you'll have seen some of the work that we've managed to get through, which we'll hear about later in terms of the community mental health transformation. Fantastic. And noting here, we've started a big piece of work around the inpatient rehabilitation pathway as well. Next slide, please. And then strategic objective 4, which is around working with our partners to add value, develop healthier and more inclusive communities. Again, something that we are really committed to doing. I think what we've seen as well is over the course of the last 18, 24 months, the partnership arrangements across our ICS as a whole have been maturing and improving. I think we've really welcomed the opportunity to work more closely with Worcester Acute in recent times, particularly around the UEC pathway, but some of the things that we're doing in terms of the out-of-hospital area, around virtual wards and the like, which I've mentioned, are really important as well. Here we've picked up some of the broader things we've been doing, which are really important as well. So working with the University of Worcester, working with our partners around housing. We do some really good work around supporting people to get back into work as well. And just note at the bottom, quite an innovative capital programme we did up in Redditch, working with the council there to refurbish and use part of the town hall to provide services out of. That's actually something that's quite groundbreaking across the country. If you look at how we've gone about co-locating services within the town hall, that's something that came to fruition last year and is something that we're really proud of. And finally, if I could just turn to the next slide. Final one, objective around being a fantastic place to work. And I guess the backdrop to this really is we have a very significant improvement programme, because we know we're not getting all of this right at the moment, and there's lots of things we are trying to do. But within that, there are some things that we're very proud of and the things that we are doing well at. We've got a really well understood staff awards process, which goes from strength to strength, I think, each year, and really recognise the fantastic work we do. Our preceptorship programme has been recognised at a national level in terms of the quality it delivers, and that it's been awarded that interim quality mark. And then we're doing things differently, trying to push ourselves around our RISE programme about how we go about recruitment and retention. And we're starting to see some of that coming through in terms of filling some of those hard to fill vacancies. We still have absolutely got some areas that are being particularly difficult, but we saw some progress. And then, as I said, just linking across to some of the work we've been doing, particularly on the improvement programme, but trying to work around the Pulse survey, the compassionate leadership training, the work with Kind Life, and lots of other things in there. So in summary, I'd just like to draw out there's a whole load of things that we've done. There were probably some things last year that were disappointing for us, but we've used those as an opportunity to kickstart some real improvement, which I'm pleased to say is going well. Mark, I'm happy to pause there. We'll take questions later, but hand on to Natalie.
Okay, thank you. And before I do hand on to Natalie, could I just, if anybody has any questions, we will have a slot at the end, as I said, but if you want to put them in the chat now, you're very welcome to do so, or you can ask them when we get to the end of the meeting. So the option is to put it into the chat now, or indeed to ask at the end. And with that, over to you, Natalie.
Thanks, Mark. So hi, everyone. I'm Natalie. I'm the Director of Nursing and Quality. And as outlined, I'm going to guide you through the quality accounts for last year and then bring you up to date with what we're doing this year. So taking a look back to last year, which is 2023-24, we had 3 quality account priorities that we signed off: shared care decision making, therapeutic environments, and trauma-informed care. So how did we do against those? Shared care decision making, which is where we involve patients and putting them at the centre of making decisions about their care and making sure it's all about the care without them. So there's a new training programme developed, and that was delivered, enabling staff to understand the principles of shared care and how to embed them into practice. The learning from that was we slightly shortened the programme, and that's now being rolled out across the integrated care system. We launched a new mental health clinical risk assessment and management policy, and we're planning then to design a bespoke training package to be launched, which will support a more person-centred approach to risk assessment. And we saw the national launch of the Patient Safety Incident Response Framework, PSIRF, which I will come back to. And that led to a far more bespoke and individual approach to patient safety reviews and improved learning. So where incidents happen, how do we approach those from a very individual basis? The second account priority was therapeutic environments. As Robert's already mentioned, we had a therapeutic garden space in one of our older adult mental health inpatient wards. We're delighted when that won Outdoor Space of the Year. Our eliminating dormitories work continued, and that saw a complete refurbishment of our health-based place of safety, our Section 136 suite, and our psychiatric intensive care ward. One of our wards opened a new sensory room and a staff wellbeing room, and that led to a safe and therapeutic environment that both staff and patients could access. We had the new accessible premises that had been opened at Redditch Town Hall, and that moved a couple of services from areas which weren't as accessible to a central, modern and therapeutic space, which has been greatly appreciated. And then we have PLACE, which is our patient-led assessment of care environment inspections. And the outcomes of those for that year was to improve our dementia-friendly environments. And on trauma-informed care, next slide, please. It's important that we thought about trauma-informed care from a patient and staff perspective and embedded it in all of our approaches. So trauma-informed care approaches have been incorporated into the cultural programme of work that Robert alluded to called A Kind Life, which was launched in March. Training in trauma-informed care has been delivered in service areas, both by clinical experts and experts by experience, and that's essential when you're talking about trauma-informed care. We had a fascinating patient story to Trust Board to raise the awareness of a need to embed trauma-informed care, and that was led by an expert by experience. We had a training session delivered to our senior leadership team, and we've incorporated trauma-informed care approaches into our risk assessment, management, policy and training. So bringing us up to speed for this year, for 2024-25, we have 4 quality account priorities. We have one around organisation improvements associated with the CQC inspection and staff feedback, a further implementation of the Patient Safety Incident Response Framework, testing of care opinion to enhance patient experience feedback, and improve risk assessment and crisis planning in our mental health services. So, why are we doing these and how are we going to evaluate them? I won't take you through the detail because that's been outlined really clearly about our CQC well-led inspection and the subsequent pieces of work. But how will we know that's having any impact? So how we're going to evaluate progress is we're looking at our pulse survey, which is a survey where we look at staff experience in our organisation 6 times in this year. That gives us really regular feedback as to the culture and the impact of the work we're doing on our organisation. And then we can make the plan more bespoke to meet staff's needs. We'll use the feedback from staff surveys in 2024 and 25 again to make sure that we're responding to our staff. We run staff focus and review groups. So, for example, when we produce a document around the staff organisation's behaviours, we ensure we do that involving our staff. And we actively seek out staff feedback on training and reflection exercises as to how the organisation currently feels. Implementation of PSERF. So PSERF replaces the NHS Serious Incident Response Framework. It's a significant shift in how we respond to incidents, moving from a much more compassionate and involved approach for both staff and patients and carers. It moves us to system learning and to really focusing on issues and incidents where we can have the greatest safety impact. Alongside the framework, we've also developed a guide to engaging patients and families and staff. So some of the feedback we often get is how do we support staff, patients and families following an incident? So that outlines how we can do that. How we'll know the progress is we've developed a patient safety incident response plan and policy, and that's been really well supported throughout the system. We've progressed that as a system-based approach. We've used systems-based methodologies to improve our learning. We're really looking for quality improvement. So where we have an incident and learnings from that, we can check out that quality improvement initiatives are being used to make patient improvements. We'll know how staff tell us if they feel supported following an incident, as well as patient and staff and carer feedback. And we'll have different learned up processes with our system partners, which will see benefits for everybody. The pilot testing and the rollout of care opinion is a new way that will really ensure that we are committed to hearing the patient and carer voice. It uses a different mechanism to the friends and family test to offer patients and carers a way to communicate with us and share their feedback. So we have an implementation to roll out care opinion across the entire organisation. We are just having to do it by service to make sure that it's bespoke for that particular service's needs. We're currently developing a dashboard that shows how many stories are being posted, the services that have engaged within that process, and then really importantly, how the services are responding to any stories that are left and identifying improvements and changes that are made as a result of that story. And that regular dashboard will be reported through our Quality and Safety Committee. And I can already feedback that that's getting a lot of positive feedback from staff and patients. And finally, the changes to our risk assessment and management process. Next slide. Thank you. So for mental health services, clinical risk assessment and management is an absolute integral part of good clinical practice. And we're moving from using a set of methodologies to a much more clear and transparent process involving clinicians, families and carers in identifying risks and how these can be effectively managed. We're using systematic approach to risk assessment and embedding multidisciplinary approach to that. We currently have a working group that's reviewing our current practice and overseeing the implementation improvements. We aim to improve the organisational knowledge on risk assessment and management. That's using national good practice and tools that are available. We've developed our own bespoke tool that's based again on evidence and national good practice. And again, we're getting very, very positive feedback. We're also ensuring that staff have the training and development to utilise the new risk assessment process effectively. And again, we'll seek out feedback from both staff and patients as to how the process is embedded. Thank you.
Thank you, Natalie. And it looks like our improvements are going well because everybody's absolutely on time. Right, we now move on to our financial performance for that year, and Denise, the Director of Finance, will cover that for us. Denise.
Thank you, Mark. Good evening, everyone. So I'm just going to take you through the 23-24 financial performance. So quick overview of our financial duties. Then I'll be looking at the breakdown of our income and expenditure. We'll be looking at what we spent our capital funding on, and then just some quick technical guidance on the going concern and the external auditor's opinion on the overall accounts. So first slide is our financial duties. As you can see down the left-hand side are the targets. So break even, all organisations do have a mandatory duty to break even. And we did set a plan of a £2.9 million surplus for 23-24, of which we achieved. Just to note on that 2.9, and one of the questions might be, why did we set a plan like that? During the planning process, we'd completed all of our plans, all of our costs, and we did have some national funding for two elements that came through late at the end, which we were able to put to the bottom line. And also some of the developments, there were natural slippage on getting staff in post, which also assisted in us having an underspend on that. So that's where the £2.9 million come from, which had no impact on any budgets that were set for our teams. As you can see from the capital resource limit, we had a £17.8 million capital resource limit. We did spend all of that, and I have a slide later on that we can go through. EFL, again, as a statutory duty. This is a cash limit that we have to adhere to, and we achieved that limit. Capital cost absorption rate. This is a dividend, a 3.5% dividend. It's a national must-do that we get charged on our assets for the organisation. And again, that's an automatic charge to the income and expenditure position. The BPPC, which is the Better Payment Protection Code, Practice Code. This equates to paying non-NHS creditors within 30 days, and we always do remarkably well on this, and as you can see, we outturned the year at 98%, well above the target. And within all of this was our efficiency programme, £10.3 million delivered recurrently, and the 2.9 non-recurrently. So overall, a challenging year. It was difficult, it was tight and very challenging, but thanks to all staff involved, that we were able to achieve all of our financial duties. Next slide, please. So just a breakdown of our total income for the organisation. As you can see, just shy of 284 million. That has grown since the last year. 96% relates to patient-related income. These are through block contracts that we have with various commissioners. So Hereford and Worcestershire ICB, Worcestershire County Council. We have other ICBs outside of our system for low volume activity. We also have income from NHS England, particularly in 23-24 was for the Agenda for Change pay award. And we also have SLAs with NHS provider trusts. Our education and training income is predominantly from Health Education England, and that covers all of our training for our postgraduate medical and dental staff, and non-medical such as therapies, psychology, adult mental health, children and young persons, and our trainee nurse associates. And there's probably nothing else really on there to say. If we just go on to the expenditure one, please. So as you can see, 79% relates to salaries and wages. So that's our staff pay costs, our employers' tax, national insurance contributions, and our pensions, plus our temporary staffing. So that's the costs of our bank and agency staff. So that makes it predominantly, 79% of our overall expenditure. Education and training, this is the non-pay element of spend, so relating to courses and seminars, conferences and the likes. And as you can see, the PDC, which is the public dividend capital, is the 3.5% that we have to pay on our assets. Capital charges is the depreciation we also have to pay on our assets. So that's anything you buy has a life, and the cost is then spread over the life of that asset. And as you can see, that's 9.4 million charge in 23-24. Next slide, please. Capital programme, so 17.8 million, so quite a large investment, a little bit smaller than the prior year because of we had less funding for the dormitories. However, significant programme of work. We've done some fantastic work during the year, made a huge difference to our service users and our staff. So 6.6 of it was national awards, so eradication of dormitories. We had some money for frontline digitisation, which is for replacing our electronic patient record, money for mental health UEC, and some national money for replacing LED lighting. Just a little bit on the estate strategy. I mean, a couple of people have mentioned the Redditch Council Town Hall. So we did a full refurbishment. It's a lease property from Redditch Council. It was innovative, and it was a partnership project, and it's believed to be the first. And actually, the Cabinet Office said that it was an exemplar of best practice of a public sector asset. So we're really pleased to do that piece of work, and that enabled us to move our talking therapies and CAM services into the Redditch Town Hall. We did some work at our Hadley unit, so some environmental work, anti-ligature work, did some work at our Warndon Clinic, some roof coverings, CCTV, security fencing, so lots of work to be done there. And then we did our mental health dormitories work. So what we saw was finalising Athlone Ward at Worcestershire, at our Elgar unit. So that finishes Worcestershire, and we're on we completed phase 3 of Hereford, which was the Cantilupe Ward at the back end of November, and we started phase 4 works at Mortimer during 23-24, which will complete in 24-25. So some great work being done there. Just refurbishing our care environments. This is all around our anti-ligature works, infection control, our net zero. So we put some PVC roof toppings on our New Haven site, and also our patient-led assessment of the care environment. So lots of work was done across various estate over the year. Quite a lot of spend on digital. As I say, a lot of that was on replacing our electronic patient record, which will finalise at the end of 24-25. And then ultimately, we have £1.9 million on leases. So this is the second year of a new international financial reporting standard, how you account for leases. And those leases for us are predominantly property and vehicles. Next slide, please. Just a couple of photographs on some of the work we've done. As you can see, top left is at Cantilupe at Hereford, section 136 suite, at Redditch Town Hall as well, and then some work at Hadley. Okay, next one, please, Fee. So just a couple of final slides. Going concern. So we have to complete a self-assessment of the long-term financial plan to ensure ourselves and also our external auditors that we have sustainable services and financial plans in place to continue operating in the foreseeable future. So it's quite a detailed financial plan. We do a 5-year plan. And actually that then we have to self-certify. That does go to board, and it is part of the external auditor check as part of their audit opinion, and that was all signed off during the financial accounts section of for the year. And then just finally, the external audit opinion. So there are 2 pieces to this work. There's the value for money exercise, and there's also the financial statements. So what we did have, we received a modified opinion, and that was noting the impact of the CQC report. So as part of the value for money, so that's all around the trust achieving securing economy, efficiency and effectiveness for the use of resources. Part of that, they did find a significant weakness due to the CQC findings. However, I'm pleased to say on the financial statements that they did not find any weaknesses, any issues or inconsistencies within the financial statements for the organisation. But overall, they did give us a modified opinion, and we're hoping that our improvement plan in 24/5 will then see us back to an unqualified opinion next year. Thank you. Thanks, Fee.
Thank you very much, Denise. And before I move on to Di and Liam, I take this public forum to recognise the work of Denise and the finance team and Robert and his executive team in delivering what they've delivered. Those 6 green ticks that you would have seen on Denise's first slide are not always seen in all NHS and foundation trusts across the country. And to see a line of 6 ticks is a great accolade to Robert and his team for delivering the management, and Denise and her finance team for some of the stuff in there as well. So thank you and well done. Next, we move on to Di and Liam, who are going to tell us a little bit more about the neighbourhood mental health teams and the transformation they've been through over the last few years. This is an area of work that is often hidden from the public, but it's absolutely critical to the care of many of our patients that we look after. Di, is it you or Liam? Or a double act?
It's a double act, but I'm starting. So, I'll just going to give a brief overview of what community transformation is to start with. Then I'm going to hand over to Liam, who will describe our achievements and challenges, and then it's coming back to me to explain feedback following the implementation. So the purpose of transforming community mental health services, it was to provide earlier identification and intervention for people with mental health problems and to support them live well in their communities. It marked a shift away from traditional disjointed pathways of care that was previously in place and moved towards a whole person, whole population health approach, which was geographically aligned with primary care networks, but also working in partnership with other NHS and non-NHS organisations. A model aligned with the recommendations of the Fuller report to ensure that primary care is resourced with multidisciplinary integrated teams at a neighbourhood level to enable them to deliver holistic care. The model was expected to start to close the gaps that had been identified in caring for people with mental health needs, in particular the gap between primary and secondary care. There was a gap between NHS talking therapies, who provided support for people with anxiety and depression, and secondary care mental health services, where sometimes people's needs were deemed too severe for talking therapies, but then not severe enough for secondary care, so they fell through the gap. The model also aimed to address rising levels of premature mortality for people with serious mental illness by providing annual comprehensive physical health checks and follow-up care. So the expectations of the transformation was to increase access to community mental health services, so more people are seen by community mental health services each year, to improve waiting times to enable quicker access to care for people within 4 weeks, and to increase the quality of care, to expand evidence-based psychological therapies for people with serious mental illness, and also introduce and measure patient-reported outcomes. As part of this, workforce expansion and new mental health roles have been central to delivering the model. So the Community Services Transformation Project was due to commence in April 2020, but was delayed until that October due to COVID. And the Trust was one of 12 early implementer sites. Planning for the implementation occurred at a period of huge change within the Trust. We were within the middle of the COVID epidemic. We just had the merger of Herefordshire and Worcestershire Mental Health Services, and there was an implementation of a new clinical record system within Herefordshire. As part of the project, we redesigned the generic adult community teams, and we pulled together primary and secondary care services, which included the primary care teams, gateway workers, the CARS team in Worcestershire, and the recovery teams in Herefordshire. And we developed multidisciplinary teams. These teams also included link workers who were employed by the voluntary sector and individual placement and support workers who work with people to access employment. The teams were based around primary care networks and renamed the neighbourhood mental health teams. The teams work with service users with mild to moderate mental health problems up to those with complex mental health problems. So they work across the whole mental health continuum. There are 5 neighbourhood teams in Herefordshire and 7 teams in Worcestershire. I'm now going to hand over to Liam, who can describe the notable achievements, but also some of the challenges that we've had during the journey.
Thanks.
Next slide. Oh, next slide, please.
Thanks, Diane. Yeah, for those that haven't met me, I'm Liam Dolan. I'm Community Services Manager for the neighbourhood teams here in Worcestershire. I think just to put the service into context, that at any one time we look after between 4,000 and 5,000 people with between 600 and 700 referrals a month. And that has been pretty stable during the time that I've been here. And also another one of our mandates is to see everybody and offer a contact within 28 days of referral, which is quite a cornerstone, something that's very important. And I'm proud to say that across the 2 counties, and we will speak as 2 counties, that we are achieving this. I've been with the service since the summer of 22. And I think it's reasonable to suggest that recruitment and staffing was a particular concern around the time that I came to Worcestershire. We were running at some stages vacancies of north of 30%. I'm quite happy to say, as it stands today, that we have well over 90% of all our posts substantively filled. I think recruitment is one thing. I think it's actually retaining is equally important. So how did we manage to do that? I think some of it was just basic good management, quite frankly, in terms of our management of our sickness, our supervision levels, mandatory training and appraisals, all of which are way over and up there with trust targets and with any other comparable service. And this continues to be maintained. I think the other emphasis that we've put down is in terms of training, not just our mandatory training, which is what needs to be complied with, but actually offering the ability for staff to grow and develop with us. And I think that growth and development has led to people staying with us and continuing that growth and development. It also is a major attraction for people wanting to come and work with us. We also looked at our skill mix in terms of what the service was made up. We had a lot of traditional roles, and we've looked to vary this over time with the involvement of the induction of ACPs, our OT leads. And I think occupational therapy has been one of our major emphasis, because occupational therapy has been a hard to recruit to profession. And I think that the leadership that we've looked to provide in terms of that is going to be important. Development posts for staff to come in, and I'm thinking particularly of nursing staff in this, that come in at a lower banding, but actually through the development that we've got in place, managed to grow up inside in the service groups. And I will move on to that or touch on that a bit later as well. But actually, a lot of the work we provide is individual, but we do provide group work as part of our provision. And again, to bring that together and to make it effective and efficient, we've put group leads in place. Mental health wellbeing practitioners have been another development, along with senior mental health professional roles as well. So as you can see, that there's quite a number across the service. Our links with our primary care networks and GPs have been very, very important, and I'm glad to say have grown. I could point to multidisciplinary and business team meetings that currently take place here in Worcestershire, in both in Ware Forest, Redditch, and here in Worcester City. And that is continuing to develop, but it has moved a long way over the last couple of years or so. And also our hours workers, which is more predominant in Herefordshire than it is here in Worcestershire. But again, it's another part of our development. One area that I would particularly point to is, and I'm quite proud of, quite frankly, is our relationship with our third sector colleagues. I think this is quite fundamental in where the whole development of the neighbourhood team ethos was formed. We have very, very strong relationships with our on-site advocacy, Worcester Association of Carers and Mind colleagues, just to name but three. And I think, to be honest, we are a team together. We rely on each other, and that is continuing to grow. Our emphasis on physical health. We all know that patients with severe and enduring, particularly mental health conditions, have an above average level of physical health illness as well. And I think that we've seen it very much as our provision, as our duty and our role to assist in terms of that, not to leave it to primary care alone, to actually to manage that. This is a service that, as part of us, that we have developed and are continuing to move. There has been a very much a co-working between ourselves and between Worcestershire and Herefordshire as part of all of this, led primarily, I would say, between myself and Diane, and that continues as we speak. In fact, we've got a manager leadership day tomorrow, again, for between both counties, and also with peer support groups. Our management is very much on the visible, it's very much on the compassionate leadership, and it's all very much on the problem solving. If you want to retain staff, it is a complex and challenging world that they work in. They need that support when they need it, and that's where our leadership needs to show its face. This is also, I think, evident in terms of our latest pulse survey results, which I think does emphasise the line management support that staff are getting. However, if we move to the next slide, for every bright side, there is other stuff that we need to be realistic about and look at. Transformation, I'd argue, isn't finished. It's evolving. It's gone a long way. I suppose it's reasonable to suggest that with the journey that we've been on, that if we show the same levels of enthusiasm and staff and the skills that they've got, there is really no end to what still can be achieved. And I think that the indicator of where we've come from is an indicator of where we could still get to. I think this is against the backdrop of national training situation for qualified staff and producing staff across all the professions is still where it is. And I think any initiatives will still take time to bear results in terms of the availability of qualified staff. And against, to be honest with you, the economic situation that we all know is out there and hasn't changed in terms of the pressure that is on the public in their day-to-day lives. Specific issues that we have in terms of challenge, though, would be in terms of complex patients and assertive outreach service, which there is a service in Worcestershire, that is a Freudian, in Herefordshire, but not a corresponding in Worcestershire. I think that is quite important to raise this, particularly against some of the incidents that have hit some national coverage over the last number of months, and where the overall provision is going to be and what it would look like. Same thing would go in terms of forensic patients with quite pronounced forensic histories that we end up dealing with in terms of neighbourhood teams. And a lot of our staff do not have the experience and skills of being able to deal with these people. Our caseload sizes, as I've said earlier, we only have a limited capacity. Every service would say that. Ours is no different. And I suppose it is going to be a challenge that if our numbers should increase, would we have the capacity service-wise to be able to give people the quality that they deserve? I've touched on staff and in terms of the availability of professional groups. I think this is particularly acute at the moment in terms of our world, in terms of medical provision. It has improved in my time in Worcestershire, but it's still an issue across the county in terms of having medical staff that are in substantive posts. There is general other issues that we could look at in terms of accommodation. It's always going to be one that's out there. Some of our team bases, quite honestly, our numbers of staff now that we're in full complement, they've outgrown the bases that they were in only a short while ago. And also what is out there in terms of our settings in the community, because with increased staffing we can go into surgeries and do a lot more work GP wise and seeing patients from in surgeries, but actually there is the struggle in surgeries to be able to provide us with that accommodation. These are ongoing challenges, and I suppose stuff that there will be need to be looked at in terms of for this service to develop in the months and years ahead. And I will then hand back to Di.
Thank you. Next slide, please. So with all the changes being made, we continue to gather both service user and staff feedback. And recent feedback has shown an improvement in both service user and staff satisfaction. Community Mental Health Survey is an annual survey for people who've used community mental health services. And in 2023, the benchmark report showed that the trust had improved its scores on the previous year. This slide here is just an example of some of the information in that report. And compared with other trusts, we performed better than expected against other trusts on 5 questions. We performed somewhat better than expected on 2 questions and about the same as other trusts on 26 questions. So you'll see. And then there were no questions where we scored worse than expected against other trusts. This slide shows the 5 areas where we performed best with service user experience, and also some areas where we could improve. And just to say that actions are being taken to address some of these identified issues. The Trust also holds a staff survey, the Pulse survey, every 2 months, and this gains feedback from staff on a number of issues and questions. Feedback from staff is improving with each survey, and the last survey, which was in July, showed highly for our service delivery unit, the area where my line manager empowers me to give my best at work, and our service delivery unit was among some of the best in the country. So it shows that although there's still a way to go in the transformation journey, it does seem to be improving, and we are getting better satisfaction from carers and staff. Thank you.
Thank you, Di. Thank you, Liam, and also Justine in the background for those on the call who was putting in the chat some explanations for some of the acronyms that have been used. So thank you, Justine, for doing that on the fly. Can I just offer a comment there as well, Liam? I think you're underselling yourself and hiding your light under a little bushel, to be honest, when it comes to that CQC community mental health survey. What the patients said about the services you provide in comparison across the nation was absolutely fantastic. You went through nice and factually, but in essence, at least one of the measures, it was the best trust in the country, and there was no measures below what would be considered to be average, and most of them were above. So there was a fantastic set of results. And if there's one set of results you want to see in the community mental health world, it's what your patients say and what your patient and carers feel, and that's what that survey was. So I just wish to point that out, because it was testament to the work that you do, and the transformation that we go through is to make things better for the patient and carers, and that's what the survey said. And so I congratulate you and all the team for that. Thank you very much indeed. Okay, we're now to the section of the AGM where we invite questions, and whilst you're thinking of any questions you may wish to ask, please show your hand, which for those of you with Teams, if you're on a laptop or a computer, it tends to be in the middle with a hand symbol with raise at the top. If you click on that, you can ask a question. And whilst you're trying to find that, perhaps I'll move to our Chief Executive, Robert, and ask him to answer Frank's question, which was with regard to the prevention agenda and how it may or may not affect us as we move forward in the short and indeed medium term. Robert.
Yeah, thank you, Mark. Could we take the slides down, do you think, as well? Like stop sharing. Lovely. Yeah, so in terms of the question, I mean, clearly there's been a stated intent to move to upstream prevention, if I could put that, for quite some time, and it's something that we really haven't managed to succeed in. I think we're expecting to see a lot more about this, and practically how we do that, how we make that happen within the 10-year plan that will be coming through. I mean, simplistically, it is a stated ambition of our ICB, our ICS, to do this, and it's something that we're committed to. The problem is always about how do you prioritise the immediate investment when the return on that investment is likely to be a little bit further down the timeline, and that is one of the real problems that we are having to address. I think we've got pockets of examples of where we've been able to do some of that. I mean, we talked earlier about the investment we managed to make in housing, for example, and some of the work that we're doing in terms of supporting people back into employment and things like that, which we know help people in terms of both their physical and mental health. So I think there's things that we as a trust can do, and there's absolutely things that we would hope to see coming in the overarching policy that would allow us to do that. In terms of the immediate, I think it would definitely be the case to say it is going to be still quite a difficult balancing act between how you free up that immediate investment against needing to see a return on that investment. And that's probably something that we are more challenged about within our system, given the overall financial position that we have, and the need for all partners to be able to move that to a balance. So I don't think there's a simple, easy solution, other than it is something we are focused on trying to do, both as a trust and a system.
Thank you, Robert. And if I could just add, from a person along with Robert that sits on the integrated care board within the integrated system, there's two sides to this. I think there's a hearts and minds side, and the hearts and minds side in terms of it being the right thing to do is absolutely one, as I think you'd be aware, Frank. And then there's actually the resources and the investment required to try and do that. And of course, we're in one of the most difficult situations in the NHS and indeed within our local system. I think most people are aware of the local system being in deficit and having to get itself back into balance over the next few years. So it's not an easy thing to do, but the hearts and mind are definitely there, and we see the leadership through the ICB, ourselves, our acute colleagues. We want to do it, but it's about trying our best to find ways of doing it, which I know is probably a bit unsatisfactory as an answer, to be honest, but it's the reality of the position we find ourselves, unfortunately. Okay, are there any other questions from anybody at all? Because that seems like a bit of an easy time, to be honest. I was hoping we could at least give our chief executive a bit of some hard questions to either field or palm off to some of his colleagues, but it doesn't look like that is to be the case. In which case, it just leaves me with a few thank yous before I close the meeting. And unusually, I'm going to start with just saying thank you to the board that I work with. They all work extremely hard within extremely difficult context, to be honest, whether that's financial or operational. So thank you very much for your efforts over the last 12 months. And I know the work that you continue to do. Thank you to our partners, our carers, our patients, your feedback and cooperation. We can't do it without partners. We can't do it without the feedback from carers and patients. So thank you for that. But the biggest thank you I'd like to put on public record is the thank you to our staff. Day in, day out, night in, night out, in some of the most difficult environments you can imagine. Our staff are there doing their best for the patients. They're doing their best to deliver the care, the therapeutic services that are required. And like I say, in sometimes the most difficult of circumstances, when they'd love to have more resources, they'd love to have more time, but they haven't got it, but they absolutely do their best. And I pay tribute on this public platform to our staff. And with that, I will bring today's and this year's AGM to a close and thank everybody who's attended today. Thank you very much indeed, and goodbye.